This is a training video for Wirral University Hospital NHS Foundation Trust. This video will go through the contraindications and indications for non-invasive ventilation and will demonstrate the setting up of NIV on a patient. NIV refers to the provision of ventilatory support through the patient's upper airway using a mask or similar device. It provides positive pressure ventilation and is indicated in patients who have decompensated type 2 respiratory failure with acidosis despite standard medical treatment. Standard medical treatment usually consists of controlled oxygen therapy, nebulizers, steroids, antibiotics and possibly intravenous aminophylline. The benefits include fewer patients being referred to intensive care for intubation, shorter stays in intensive care and improved overall mortality. For patients who are in decompensated respiratory failure, we often have a plan of care which deals with whether we would escalate the patients for intensive or critical care or whether this would be a ceiling of treatment. Patients are selected with usually blood gases of a pH of less than 7.35 and a PCO2 of greater than 6 despite this standard medical treatment. This is Sister Amin and she's going to show you how to measure, size and place a mask for NIV, and then we're going to talk to you about the NIV settings. Okay, Sister Amin, can you show me how you would size a mask for non-invasive ventilation?
Yeah, well, we have the sizing charts here. Let me just take this off you, Mrs. Jones. And we'd place this under the chin and we'd measure to the bridge of the nose. So this patient is a small.
Okay.
I already have my tubing set up here and the mask in place.
Okay, so if you wouldn't mind just showing me how you would fit the mask to this patient and then we can go through the ventilator settings.
Yeah. Place the mask under the chin to begin with, and then over, straps over the head, clip in place, and then we are going to tighten the straps, the bottom straps first, and then the top straps just go lightly across the head. Not too tight because this will put pressure on the bridge of the nose and that's how your patient could end up with a pressure sore. You then pull this out slightly so air fills the seal and then that helps cushion the mask and it's more comfortable for the patient.
Okay, so the patient looks fairly comfortable on that mask. Would you just now go through the settings for us on the machine? Okay, so this is the Respironics BiPAP Focus machine and you can see a selection of settings. The first setting that we look at is the ST mode, and what this means is it's a spontaneous time pressure support. That means that the breaths are triggered by the patient. The machine will also trigger a breath based on what we set if the patient doesn't spontaneously breathe. Underneath that is the IPAP. Now, IPAP is inspiratory positive pressure. It's a boost of pressure that helps the patient take a comfortable breath. It helps improve ventilation and decreases the work of breathing. IPAP generally helps blow off carbon dioxide. I can see that that's set on 10 there. Is that the starting pressure for IPAP?
It is. Yes.
Okay. Now underneath it is the second pressure, because this is bi-level ventilation, and that says EPAP. And what EPAP is expiratory positive airway pressure. It keeps the patient's air passages open, helps splint their airways, and helps improve alveolar ventilation, improving oxygenation. That EPAP is set on 4, and would you say that these are the settings that you would start off for a patient with non-invasive ventilation?
They are. We'd always start on 10 and 4, and we'd always have a pressure of 6 in between the IPAP and the EPAP.
Okay. Now the next setting down there we're looking at is rise time. Now rise time is the amount of time it takes for the machine to change from expiratory pressure to inspiratory pressure. A setting of 1 is the fastest time, and a setting of 3 is the slowest. You should really adjust the rise time to find the most comfortable setting for the patient depending on their respiratory rate. The next setting underneath that is the I time. This is the inspiratory time. If the patient doesn't spontaneously breathe within a set time, then the machine will take a breath. Underneath it, the options are to ramp time, and just if you use a ramp time, then this generally starts the machine at low pressures, gently and gradually increasing the pressures to the prescribed setting. So they're the basic settings there now. How would you assess whether the patient was tolerating and there was a good seal for the NIV?
You would check your leak, which is here. This machine will tolerate a leak of up to 60. As you can see, this is 1920 on this patient, so that's fine.
Yeah.
And your trigger here would say whether your patient has spontaneously breathed or the machine has triggered a breath.
Okay. Right, so we're satisfied with those settings, and the next thing to do is just check the patient's tolerance. And Mrs. Jones seems to be tolerating the NIV quite well. Can you just explain to me how you would monitor a patient on NIV?
Yes, you'd be monitoring their oxygen levels and their blood pressure, and for the first 24 hours you'd also be monitoring their cardiac output with a cardiac machine.
Okay, now you mentioned oxygen levels there. Now this patient has decompensated respiratory failure, and if we think about the oxygen guidelines, can you tell me what target saturations you would be satisfied with for this patient?
Oxygen saturations of 88 to 92.
Okay. Now if you weren't achieving those target saturations, is there anything you could do to improve oxygenation?
We could put oxygen on the patient.
Okay. Can you show me how you do that with the NIV mask?
We have our green tubing, and we would just insert the green tubing onto the mask, and then we would titrate the oxygen so that oxygen saturations were 88 to 92.
Okay, that's great. Now in this type of patient, what sort of PO2 might you be looking for?
PO2 of 7.3.
Okay, so you'd be satisfied with a PO2 of greater than 7.3. And if the patient had cor pulmonale?
We'd be looking for a range of 8.
Okay, that's great. Now, the patient will be kept on non-invasive ventilation for as long as possible in the first day. When would you do a blood gas to see whether there'd been response to treatment?
We'd first do a blood gas an hour after putting the patient on an IV, and then if they are responding to treatment, we would then do a blood gas 4 hours afterwards.
Okay, So if the patient was showing a good response to NIV, then how many days would you continue the NIV for? I do appreciate this is a bit individual, but generally.
Generally, it would be a 3-day weaning process.
Okay. Now, if you did a blood gas at 4 to 6 hours time and the patient showed no change in their blood gases or clinical state, what sort of things might you be thinking about?
We would be maybe changing the pressures on the NIV machine. We'd also be getting a senior medical review and maybe discussing escalation to ICU.
Okay, so it's really important that you've made decisions about ceilings of care here. So if the patient's not responding at 4 to 6 hours despite maximum medical treatment and pressures on NIV of 20 and 6, then we need to think whether they'd be escalated for critical care or whether we may need to introduce some palliative measures. Okay, so we've gone through how we would place a non-invasive ventilation mask on a patient, how we would work our way through the pressure settings, and we've talked a little bit about its indications and contraindications. Thank you.